few words for the viewers. Yes, before we go on to the stage, we need to know how we do the staging. Okay, apart from a local imaging, which can involve a CT and an MRI, we do make use of the PET scan to see how far the tumor has spread. So coming back to your question, just for a layman, if you thought is stage 1, okay, it's stage 1 is a confined small tumor in the kidney, which has not involved the fascia, which has not gone out of the kidney, has involvement in renal vessels, and there is no involvement of the lymph nodes. That's one.
Right.
A little bigger in size, without, again, node involvement, venous involvement, okay, might have touched the fascia of Gerota, maybe a stage 2. Whereas, by definition, when you say stage 3, that means it's a locally advanced cancer where we might get a renal hilar node positive, ipsilateral, or might be a contralateral. The tumor is a little larger enough. It might have involved the fossa. It might start involving the surrounding structures, maybe on the right side the liver and the left side the kidney, the perinephric fat, and that's the locally advanced ones, okay, which sometimes become difficult for a surgeon to take it out.
Right.
Whereas the last stage, where we are really afraid of, and that's the stage 4 cancer, where the cancer cells, any size, the tumor can be any size. Yes, nodes are positive, they go to the lymphatic vessels, and then these cancer cells go to the blood, and once they get into the blood, it goes everywhere in the body, starting from the liver, the bones, the lungs. And these are some of the common sites where these small micrometastasis starts lodging in and starts developing into a bigger thing. And that's what we are very afraid of. That's the last stage of cancer, and that is stage 4. And again, Aparna, to all the viewers, yes, if you try that you don't come in the last stage, that is the stage 4. And if you are able to pick up in stage, the 0 stage also, and stage 1, stage 2, 3, yes, renal cell cancer is curable. We can do a lot of things with surgery and the newer modality, but stage 4, everything becomes palliation for us. That's the importance of staging. Say, like that, chronic kidney disease, but then we need to know what is the chronic CKD. Is that incidentally, like how we detect myeloma in a chronic CKD, we might develop a renal cell cancer, but then a CKD might not, okay, plus or minus, might not directly related for the development of cancer. Okay, otherwise then we would have got a large number of renal cell cancer ways. One is the anemia related to the disease and renal cancer. One of the presentations of renal cancer may be just anemia. Okay, that you come, you are fatty, you are pancreatic, you are very tired, you look, and it is per se a presentation of the cancer. And as the cancer advances, you might have more grade 3 pallor and anemia. Next is the other anemia is related to the use of TKIs and the therapies and related to treatment. Okay, so yes, it has to be handled in a little different way. Once you treat the tumor and the tumor becomes tumor-related, anemia gets covered and also related. So what we do over here, divide anemia into, depending upon hemoglobin, into different categories on the trust. Now, like if you have quite a low hemoglobin, say about less than 7.5 grams per deciliter, definitely you will need a transfusion at least 1 to 2 units to put you back into around 8 to 9 grams. And that's a little comfortable hemoglobin where your quality of life will be a little better. Yes, if you have a hemoglobin ranging from 9 to 11 and still some sort of tiredness, weakness is there, yes, we do have drugs for like erythropoietin, which is erythropoietin stimulating drugs, and it's quite well played with the kidney cancers. With this, this is also altered. Yes, you can give darbepoetin, erythropoietin, and that helps. And the range is between 9 to 11 to make it up another, to make it to 13 and 14. Now, there is an in-between group which ranges between 2, 9, and 10, which might, yes, in fact, all anemias needs to investigate it as per protocol. That is, you need to see there is iron deficiency anemia, megaloblastic anemia, macrocytic, microcytic deficiency anemia. That goes without, where we do the MCH reticulocyte count, we see the peripheral smear, and also supplement. Vitamin supplement is important, B and 12, iron supplement, folic acid supplement. And this particular group, the middle group, which has a hemoglobin between 8 to 9, 10, there is, and even 9, 11, there is also an therapeutic option of iron injection. It's iron sucrose. Many of our patients, we do give intravenous iron, elemental iron, to increase the hemoglobin. Okay, so we need to just cannot fully categorize them together. Yes, depending upon the causes, what are the underlying other factors. Yes, treatment has to be individualized. But one thing, Aparna, I want to add, when we have treatment, these TKs and we all immunotherapy, we need to also counsel the patient that there is a side effect and you are to be aware of it and you need to cope up with it because everything cannot be treated. And that's what helps the patient. A little bit of discussion, a little bit of bringing them together. Yes, you have, and that gives them a little confidence. And then, okay, you need to also adjust with it. All the anemia cannot be corrected. Yes, some can be.
Right. Yeah.
Lifestyle related things holds good. And I think it falls common for all cancers. I told separately, yes, definitely for kidney cancer, we advise our people, just first very thing, if you have comorbidities, please do consult your physician, and it may be a little more regularly so that your hypertension, diabetes, thyroid problem, or any other neurological other problem is under control. That's one of them.
Right.
Definitely an 8-hour sleep is the advice. Good quantity of water, but depending upon your output of the urine, yes. And a kidney cancer, we always take a consultation with a nephrologist. It is always better to get their guidance and go, particularly when we have removed a kidney, okay, or you are having a CKD, okay, so these are the basic things. We advise them, please go meet them and come. Yes, we ask to take them lots of vegetables, maybe fruits. Some of the fruits and vegetables might be a contraindication, like coconut water, more of potassium, please avoid. So these type of, but more of green and multiple vegetables, and that's what the WHO says, 7 colorful vegetables and 7 colorful fruits. Okay, decrease the quantity of the carbs. Anyhow, that holds good for everybody. Sugar content, less of salt, less of carbohydrate, and less of your spices is how it has to go. Yes, you need all freshly prepared food. And I always tell my patients, don't take the full meal because you'll not be able to finish it during your treatment. We split it up into multiple diets, maybe 6 times a day is what you can have. And also on the psychological point of view, we do tell to have your whatever you like. Yes, that will be a better thing if you can eat what you want to eat. We also tell them to avoid smoking during this time. Don't smoke, to restrict your intake of the alcohol. If you're taking or don't take alcohol, that will be better. And regarding red meat, definitely not, because alcohol, tobacco, red meat are all under the same umbrella of very high rates to multiple comorbidities. Yes, white meat we do allow because people will ask about non-vegetarian food. Yes, like chicken, but it should be cooked at home, non-spicy, less of salt, and maybe a grilled along with the vegetable is what the Western diet has. It should be a better option, but it should be cooked at home. That's what we tell them. Sometimes our dietitian, depends upon which place I'm working, does have recipes to make these foods, what I have told you, into a better palatable and more gooder option. So that makes the food little much better. That these are things we do put them up into dietitians, but because clinicians may not get a time to tell so many things. We do have a written thing which we handed over to the patients. Yes, kindly follow. Right. Another thing, Aparna, we do tell them to do yoga, but it can't be the biggest yogas and all. You can have online yoga consultation, yoga that fits your body, keeps the blood circulation, and meditation is again another aspect which gets already incorporated in the yoga. It makes you feel good. It increases the circulation. It increases your power. And that also keeps you going.
Right.
And lastly, one point, immune booster, I also do in my TV programs. Yes, it's a common question asked everywhere. Do you need to eat anything which is natural to boost your immunity? Yes, there are 10 to 12 ingredients. One is lemon, one is tea, green tea, one is ginger, one clove, dalchini, turmeric. Turmeric has a huge amount of antioxidants in them. And these are some of the other things, so many, all those clove, cardamom, and everything adds to the ginger. Okay, so when we add all of them together, they all add to the immune booster. Only it prevents you from the getting the side effects less in a cancer, but it also fights you the COVID. And these discussions keep coming on with the COVID pandemic around with the treatment of cancer. So a little bit of holistic approach. Yes, we clinicians need to spend some time to give them, but then we do put them up into physicians also, dietitians also, which will take them through. That's what I feel we can tell them for lifestyle related behaviors.
Thank you. Thank you, Dr.
I think that is also the this year's motto or the slogan for the World Cancer Day on 4th of Feb, bridge the gap.
Right.
That's what we are looking at, bridge the gap. Many of these medicines are exorbitantly expensive. I work in a medical college setting as well as in the private sector. So when I'm in the medical college with whatever Ayushman Bharat, the Tamil Nadu chief ministers, the approval per patient for the drug is not more than 5,000-6,000 rupees. Okay, and it never goes up to 10,000 rupees. So we cannot discuss about all this, what we spoke today, giving immunotherapies, TKIs. I told so many things to be given. That's only anything which is cheaper than 6,000 or 7,000 rupees can be given. We do have sorafenib. And thanks to Biocon, and I think there are 2 more companies which have already come with the pazopanib before this. So we have started using pazopanib, sorafenib, and 1 company has come with the generic sunitinib. So that's all we can give to 70% of the Indian population. So there's a big gap in the treatment. Rest, immunotherapy, TKIs is only for 5%, maximum 10% of a diagnosed renal cell cancer. So in India, a big gap exists, and our motive at this point of time is how we bridge the gap. And I welcome companies like Biocon coming in with more generics, but the cost has to be really cheap because the treatment continues till you progress. So, so to make it more affordable care for the needy,